So I mean, SARMs is a huge thing that we get about and things like that. And I think some people have asked. I think you got asked before, like, oh, is this going to be the new thing in the performance-enhancing drug world? And you're like, it already is. It's been here.
It has been here for a long time. Like.
Okay, hi and welcome back. We're here with Jean-Francois Tremblay, but today we're going to talk about things that can affect physical performance. So it can be SARMs, because people have a lot of questions about those. But welcome back, JF. How you doing?
I'm very good. Nice to be back with you guys.
Yeah, thank you. So I know we've done a few other videos on healing and age management stuff and anti-aging sort of peptides, but this is quite a popular sort of area, obviously, physical performance, muscle building, enhancing performance. So, I mean, I'll let you lead the way on these things. So, I mean, SARMs is a huge thing that we get about and things like that. And I think some people have asked. I think you got asked before, like, oh, is this going to be the new thing in the performance-enhancing drug world? And you're like, it already is. It's been here.
It has been here for a long time. Like, you look at one compound, GW, was banned by the WADA in 2007, I think.
Right.
That means it was heavily used even before that. And the first studies, again, they go back to the 90s. So it's not new. SARMs are actually, many years ago, there is one class of compounds. They're anti-androgen. So widely used now with transsexuals. You know, you want to shut down the effect of the androgen and all that. They're still used.
Yeah.
But what they found is that they had kind of a specific effect, some of them, on bone and muscle. They were very specific to those receptors in those tissues, but would block those receptors instead of stimulating them.
Okay.
And they had a higher affinity than testosterone. That's why the blocking would occur. So some guy in his lab one day thought, hey, what if I modify that molecule to have that high affinity for those specific receptors, but instead of blocking them, it would stimulate them.
Yeah.
And they started to modify a bit the molecule, not that much, and bang, SARMs were born, basically. So in a way, they're not new, because in a private talk, you know, they say, yeah, they're new. We don't know what's going to happen. Well, yeah, they are not new like people think. They are new as they're newly known by the general public, but they have been around for almost 2 decades already. And they come from another compound that's been around for at least 50 years.
Okay.
So new is relative. And that same talk, I remember back in the 80s, we had those same questions about anabolics. You know, they were kind of new to me at least. You know, I was only 20, and I don't know what's that. Yeah. So, and between us, we had those questions. Yeah, but down the line in 30 years, 30 years passed, and nobody showed up with a tail or a third leg. Now, and cancer. There are some cases where they would aggravate the case of cancer, not provoke it. See, that's another thing. Same for growth hormone. You know, back then there was this guy who had a huge brain commotion, and I think he died. And they said, no, he was taking huge amount of growth hormone. Yeah. Nothing to do. He had a commotion, you know, a concussion.
In his head. I think I read about that. He's a football player, maybe. Something
that's right. So, you know, but the thing is, the health bodies like Health Canada or your health body in the UK or the FDA in the US, they take the wrong route about that. They demonize those compounds for moral reasons, and they scare people. Yeah. But people are not stupid, and much less now with internet. They get more education, good and bad, but overall, so they just take the wrong route. You know, it's going to kill you. Don't do this, don't do that. And people start to look. let's take the case of anabolic steroids. Okay, back in the 80s, very bad for you. Now, 90s, AIDS spreads out.
Yeah.
A huge amount of money is invested in research. So they use it to look, the main problem with AIDS people, one of the problems they had is that they were losing a lot of body weight.
Mm-hmm.
So they say one group of researchers, they said, okay, what can we do so they don't lose so much body weight? So they look at insulin therapy, which is very anabolic. They looked at anabolic steroids.
Mm-hmm.
So now suddenly they're not so bad anymore. And I remember one study where they gave 80 milligrams a day of an oral steroid, Anavar. And in the study, with AIDS people, so they had kind of their liver wasn't working too well.
Yeah.
They saw an improvement in the liver function. So now it's not
with an
bad
oral.
yeah. So now it's not bad for the liver anymore.
Yeah.
So
interesting.
it depends, and by experience, of course, I wouldn't suggest high dosages of anabolic steroids to a 60 years old, but they're not that bad. They do have their side effects like any drugs and hormones. If you take too much, try taking too much insulin. You'll understand what I'm saying.
Yeah, exactly.
But they're not that bad either if you know what you're doing and you have a goal in mind and you waited, for you, benefits, drawback, and you make that decision. You understand? It's not, but morally, it is demonized. And now the tendency in that same line is to demonize SARMs when they're actually better than steroids. They do have side effects like any drugs. In pharmacology, you say you don't have an effect if you don't have side effects. Actually, the side effect is a negative effect, and what you want out of it is a positive effect. But it's rare you don't have that thing. Now you balance out what you want. But in general, they were developed specifically to replace testosterone replacement therapy, both for men and women, because much less side effects. Now, I don't think it's a good idea to totally replace them with SARMs because, again, testosterone has effects in a lot of other tissues outside of muscle and bones. So you want those effects. But what I've seen a lot of time with amazing results is to decrease a bit the testosterone levels and add a SARM. So you kind of boost that anabolic effect. And then, yes, you will see greater muscle gain without with less side effects than a higher amount of testosterone. And people are very happy with that.
That was the thing, wasn't it? Anabolic steroids, the guy, correct me if I'm wrong, but like the aim was to try and improve the ratio of androgen to anabolic.
And
right?
Exactly. And not SARMs, they went to the other level. And in that sense, maybe too far. It's maybe too specific to be used alone. Because of that,
you need the androgen part, right? Women and men do
up to a point. That's right. So you need that. So that's why a combination of both, the normal dosages for that purpose, that's a great thing. People talk a lot about the inhibition of the HPTA axis. No, it doesn't happen with SARMs at all. What you'll see sometimes, it's a lowering of your testosterone levels, but that's not due to a shutdown of the pituitary. It's due to decrease in production of the SHGB, steroid hormone globulin binder. So you lower the level of buffering of testosterone. So when your blood level goes down, then some more is released from that globulin. So if you have less of it, it's harder to maintain those higher levels. But again, if you inject testosterone, those levels will be maintained because it doesn't all go in the bloodstream. So that little 1 or 2 ml of oil that's in your muscle, that's your buffering agent for testosterone. How is it released from the oil? It's a gradient of concentration. So if there is less testosterone in the blood, more will be released from the that oil bubble. So it will compensate. Because and again, about the SAGB, it was shown that if you lower it, testosterone level go down. And if you look at clinical results, people who take SARMs with lower testosterone, their LH and LSH is not affected. So that means there is no inhibition at the upper levels at all.
Interesting. So these people that are taking SARMs with TRT, are they just taking them like indefinitely, or is there a benefit to like taking a break because of that SHBG, or?
It's a replacement therapy.
Yeah.
Unless what you're replacing is coming back naturally, it's for the rest of your life.
So you'd stay on a mix of TRT, lower dose.
Of course, not those dosages that are taken by athletes, like 20, 30 milligrams.
Yeah.
But what they were intended, and usually for that purpose, it's from 1 to 5 milligrams, no more.
Interesting. Yeah, with TRT. So can we go through some of them? Because I've done a bit of reading, but there's different sort of names of them, and I know they're associated with which company was looking at them.
The name like RAD 140. RAD is for radius, and 140 is, I don't know, maybe they had 1,000 molecules, like from 1 to 1,000, and it's the variant 140 that showed the most results. So it's always, they number things. The most popular, the first and the two first to come out and most studied were LGD 4033. And the Ostarine, which is MK 2086. MK is Merck, the company, and LGD is Ligand. They're the most popular for the simple reason that they have, people are sure that it's all good. It has been used longer, more studies done on humans and animals, and the safety have been shown. Doesn't mean they're the best. To me, the best is RAD 140. Why? Because looking at that anabolic, they pretty much have 95 same anabolic effect as testosterone. So 1 milligram of SARMs will give you pretty much the same anabolism as a milligram of testosterone at low dosage. If you go higher, then the SARMs win, because if you take 100 milligram of testosterone a day, part of it will aromatize, part of it will turn into DHT and other metabolites, so you won't get the full 100 milligram of your testosterone because of all those conversions. SARMs, if you take 100 milligram, you'll get 100 milligram anabolic effect. So as you go up in dosages, slowly SARMs become better. But at lower level, it's very much the same. But the androgenic effect, the ratio with LGD, it's 10 to 1, meaning that it's 10 times less androgenic than testosterone. And actually, that's not that great, because we have anabolics already that have that ratio. But then you go to Ostarine, and the ratio goes, it's 20 times less androgenic than testosterone. Now, that's great already. We don't have any anabolics that do that, so that's a plus. But then you go to RAD, and it's 90 times less androgenic than testosterone. So practically, it's a pure anabolic. In terms of clinically, it's a pure anabolic.
The best thing that's been made, I suppose, in terms of
and proven. The other ones, I don't know if they do or if they don't. It wasn't studied, but they did study it with RAD.
Mhm.
RAD has been shown to bind to the DHT receptors on the prostate and not activate it, so it protect the prostates against your own testosterone. So that would help to delay any incidence of prostate hypertrophy or ultimately cancer.
Okay.
So that's a proven effect. It protects the prostate, and it has shown neuroprotective effects in the brain. So increasing BDNF and other factors that are good for the brain. Not saying that the other ones don't do it, but we don't know. This one we do know it does it.
Is it better than testosterone in that sense, though? I mean, do we know whether replacing like RAD with some testosterone would give you a potential benefit? Or I suppose you could take more of it with fewer side effects, I suppose.
Yeah, and actually for people who are still not sure about, I don't know, it's always the same thing. RAD or SARMs in general are demonized. But then you have studies, like right now there is an ongoing study done on women, and it seems to show that 100 milligrams a day of RAD 140 helps to fight breast cancer with women who have breast cancer. So it
and that's a big dose, right? 100 milligrams. I mean, normally,
no, you take that and better hit the gym because you're gonna get huge amount of muscle. A high dosage for men training would be like 30 milligrams, and it's like,
really,
it's kind of the sweet spot for huge muscle gain. 30 milligrams is everybody. It's like, whoa. 100 milligrams. I wish those women don't hit the gym during the therapy because they're gonna get huge.
Yeah.
So suddenly something that was no, don't do it. It's dangerous. We don't know. Now it's starting to show positive effect, even in cancer fighting. So,
I mean, I was going to when you mentioned anabolics earlier. This is the Nelson Virgil book, right? This is the one where he talks about how to use anabolics
built to survive.
It built to survive in HIV. So you literally, you're right. So that was the turning point of it being more accepted. So maybe we're hitting that now with the SARMs.
That's right.
So what about, so guys will want to know, like dosages that people use. Obviously, there's no recommendations here, but it's just information.
No, what I've seen, most SARMs, people would start to assess at 20 milligrams a day.
Okay. Of all of them, or is that RAD 140 only?
All of them. They're pretty much, even LGD, they go for lower dosages because there was those human studies, I know 1 to 5, but no. Athletes who want a big kick out of it, they take 10 to 20 milligrams.
Yeah.
And for Osterine and RAD, it seems like what I've seen, the sweet spot where you get like the full anabolic effect, 30 milligram is like, whoa.
Yeah. And you were describing how, because there's not conversion to things like estrogens, you don't really get a lot of like water retention that those things might cause, and it's more of a gradual.
Well, you may still at higher dosages because there is still that slight androgenic effect. Okay. So somehow, normally the body doesn't know what to do with it except excreting it, but it won't aromatize it. It won't. But there's probably in the cascade of events, the body detects that there is too much anabolism, and one of its reaction will be then it cannot aromatize the SARMs. So it may turn to your own testosterone. So you may, at higher dosage, you may have some increased aromatization of your own testosterone in an attempt to lower that general anabolism effect. You won't see that at lower, like 1 to 5 milligrams. You won't see that happen.
I suppose if you're on TRT and you decide to take one of these compounds, that if you're getting that lower SHBG, you suddenly get an increase in your free testosterone, that could aromatize more as well, which is probably why people drop the dose of TRT.
Exactly, of testosterone. Usually a good a good practice I've seen done is to cut in half what you are taking in testosterone, and introduce a SARM.
Yeah.
So you'll get the best of both compounds.
Have any of these SARMs been approved yet for any of the marketing authorizations in the different countries?
No, not yet.
But maybe
Is there one that's close?
maybe.
Yeah.
Soon, I think Ostarine is about to, and RAD with those newer studies in humans, against breast cancer, and I'm sure more will come out. Probably it will be, but because companies were a bit slow about them, I guess they didn't see a huge market for it. So the patents expired. Listen, pharmaceutical company, their first goal is to make money to their people. Second is to have a good compound, but it's really second. And if they don't see the money making capacity of a compound as good as it is, don't expect it to be released.
Yeah. Interesting.
Do they have to report a dual use for it then? Is that why they don't get approved? Because they would have to tell the regulatory agency that yes, this might be for cachexia or muscle wasting, but then also be abused by an athlete. Therefore, they've got to report both of those back.
No, I don't think they need to report it. I'm sure that the health bodies already know about it. But actually, it may help in terms of approval, because being approved, then you have the legal route to go after the companies that make it kind of on the side, in that gray zone. So now they say, no, now, it's a pharmaceutical compound. You cannot make it anymore. You go against the patent or whatever.
Yeah. Interesting. So what about injectable SARMs? That's a new thing. Like, people are saying that when they've tried them, it might be having less of an effect on things like SHBG and getting more, per the dose.
I
heard of anything?
I don't know.
Very new, I think.
Effect on SHGB or any other effect, I would need to see blood test. Compare, for example, the same person who used one compound for a couple of months. Stop, then do the injectable and actual results, and then do a group study. Actually, physiologically, I don't know why it would do. It all comes from the fact that injectable steroids are safer for the liver. Because they're not methylated, so they pass only once through the liver, and you don't have that harsh thing happening. That doesn't happen with SARM. So, from what I know, I don't see how it would be better. Absorption orally is amazingly high. You just little bump in absorption if you inject. I'm not saying it's not happening. I don't know. And I don't see how from what I know. Nothing I know could explain why it would be better. It may still be. I don't know.
Apparently, some people report, even with the oral SARMs, that their lipid panels go off in terms of it worsens the HDL LDL sort of ratio.
That's another side effect. But most people who went to see the doctor, of course, two things: the liver enzymes went up a bit, liver panel change, and the question from the doctor was, are you taking anything that I don't know about? So everybody who told them, yes, I'm taking this, then the doctor calmed down, because those are not, how do you call it? It's not pathological. It's due to something you're taking. So if you had those same changes and you're not taking anything, then you should worry, because something is wrong.
It's like erythrocytosis secondary to testosterone treatment. If it came out of the blue, then they might be worried that it could be part of polycythemia, but it's due to the testosterone. Therefore, you can put a
exactly. It's the same thing. And as for the cholesterol, and it's actually a rise of the bad cholesterol, is when they do fractions for blood test. It goes deep. They take all those cholesterol fraction, but it doesn't affect the real bad ones.
Yeah.
And you have to keep in mind that whole cholesterol thing. If you adhere to the cholesterol theory, yes, it would be a bad thing. But,
The theory
just
that,
keep in mind, 75% of the worldwide admission in emergency for heart-related conditions, 75% of those people had normal cholesterol levels. Only 20. So it was not a good marker to predict that at all.
Yeah, and that statin study, wasn't it? The study that they pushed for statin use, they actually ended up
you do the reverse, because you mask the effect. You bring down, because cholesterol is a marker of what's happening. It's not the actual problem. So if you take statin to lower cholesterol, the actual problem is still be there, but not you even get rid of the marker. So excuse my French, but then you're fucked, basically. You won't see it coming at all.
I mean, there's also lots of talk about, if the HDL goes too low, then that could be a problem. But
of course,
there are some papers, I don't know if you've got any knowledge on this, where the reverse cholesterol transport is enhanced with things like testosterone. I'm not sure if it's enhanced with SARMs, to where it kind of counters the negative effect of the lower HDL.
See, it's very, exactly, it's a very complex thing, and you cannot jump, it raises it, it's bad. No. You really have to look into all that.
But multifactorial. I mean, I've watched and listened to plenty of things where they're debunking the cholesterol hypothesis and how
there are books written, very good books, and it's hard to go away from that because it's imprinted in our subconscious. Cholesterol is bad. Not acknowledging that our liver makes 2 grams of cholesterol, has the capacity to produce 2 grams of cholesterol per day. So if you don't eat enough, you're going to make it. So it's that essential to your functions. So how bad can it be? And as I say sometimes, if it was that bad, well, somebody would have come from the future to stop me. So
we've done SARMs, right? That's correct? Right. Are there any others you think was that quite a good summary? Do you think there are any others that you put in the performance side of things that maybe?
No, if you want to stay on the safe side, that's pretty much it. Steroids actually in low dosages are not bad. There are people doing their TRT with some anabolic steroids or a mix of testosterone. There is even a couple of them that have mild anti-estrogenic activity.
Type derivatives and things.
For example, like 100 milligram of each.
So it needs clarification because there's a lot of misinformation out there about it.
And with TRT, there just isn't one way to do it. It has to be individualized for you.
No, and there is a big trend that actually started in Europe. I've heard, that's not my specialty like that deep, but that idea that you shouldn't inhibit the estrogens. We do need estrogen. The other way is you cut off too much estrogen, the first thing you'll know, all your joints will you have pain. So, and now there is one school of thought, they say, no, let it go.
But guys enjoy this content, so thank you very much for coming on. I mean, thank you for coming on, and we'll see you next time.
So, okay. And for everyone else, if you want more content like this, just hit the notification bell and subscribe to our channel, and also the like button if you like the content today and future content. So thanks again for watching and subscribing. And thanks, Jean-Francois.
Hey, you're very welcome.
Thank you.
Thank you.
Okay.